Good morning, everybody, and welcome to Grand Rounds, virtually speaking. We just mentioned that our Grand Rounds next week will be one of our award lectures. This is the Emily Mumford Award Lecture, and the speaker will be Kelly Kelleher, who is a distinguished professor of pediatrics and public health at Ohio State University, and it'll be on a Marshall Plan for Child Development, Neighborhood Interventions. Make a couple of announcements. I'm not going to announce the NOGAs, the Notice of Grant Awards we've received, because they've become so numerous that they would eat into the time of our speaker. But we will publicize those. But suffice to say, obviously, even though we haven't always been on site, people have been hard at work, and we've been experiencing a real run of success with respect to funded grants. So keep up the good work. To mention that this is National Suicide Awareness Month, and this week, actually, I attended a conference that John Mann and Jeff Thompson, who are affiliated with in addition to our department, the New York City Police Department, they organized a 3-day international conference on resilience for police, which had 2,000 registrants. Which was quite extraordinary. It just shows you the extent of our faculty's involvement with the population at large and societal institutions, and it was really impressive. So congratulations on them. In terms of the COVID update, we were just talking with our speaker today about what's our anticipated prognosis for when things will calm down and normalize, and I think we're in agreement it's not going to be for any time soon, and possibly well into 2021. And apart from that, I think I would just add that in addition to what I just said about the time frame that we're looking at or speculating about, we've done a good job in terms of first stemming the tide of the COVID surge, and then adapting to how to manage the delivery of services to our patients, as well as continuing to provide support for our colleagues during this crisis. So we've learned the new way of functioning. The problem is that things are changing with any recrudescence in the infection rate or changes in the guidelines that we get from the state. Also we're marking time with things that can't wrap up to full speed, like clinical research or like on-site procedural-based treatments. So that's something we're continuing to try and move forward on, but it's a very slow process, and often one step forward, 2 steps back. There is some kind of economic consequence at the end of it that we're trying to anticipate the extent of, and make arrangements for how to deal with. But it's to say that we shouldn't be deluding ourselves that there's going to be light at the end of the tunnel anytime quickly. It'll be into next year, and the good news is I think the task force for managing this, led by Lou Baptista and Evelyn Attia and Blair Simpson and Melissa Arbuckle, have done a great job, but we're going to have to keep doing it for a while longer. Well, today we have, he's an inside speaker, but really an outside speaker, because we hadn't really had him present to us before, been on our radar screen, even though he's been right next door and is somewhat, professor in the emergency medicine, looking at his a very novel and maybe unique discipline of global emergency medicine. So, but let me start from the beginning. So Dr. Spencer went to undergraduate school in Detroit at Wayne State, and then received his medical degree from Wayne State as well. Then he went on to a series of postgraduate training at Columbia, and then at Johns Hopkins, where he was with the International Committee of Red Cross Certificate Training, and humanitarian emergencies in large populations. And subsequently, um, he did an international health fellowship at the Hospital for St. Louis in Paris, France. And subsequently has pursued emergency medicine, which is a popular discipline for people who like to be kind of on the front lines and in the center of action when you're young, but often sort of takes a toll over time. But beyond just being able to enjoy and grow professionally in that context, Dr. Spencer has taken a different tack in that he's done this in numerous countries and different cultural settings. So just to give you a little bit of a flavor for that, I just want to mention some of the tours of duty that he's done over the course of his career. So earlier in his career, he did a medical school elective in emergency medicine on the Navajo reservation in New Mexico. Subsequently, he was in Africa doing epidemiological work on non-food item beneficiaries, a verification report for Rebuild Hope for Africa. Subsequently, he was involved in a mortality survey project as a lead investigator, doing outbreak investigation and case control studies, the pregnancy surveillance project in Kigutu, Burundi. After that, he was deployed to New Guinea, where he functioned in an Ebola treatment center for Doctors Without Borders. Subsequently, he also did another stint in New Guinea, where he was working as a national epidemiological coordinator for Doctors Without Borders. Another stint in Burundi, where he was doing trauma and emergency medicine. And then in Chad, where he was an epidemiologist in the hepatitis outbreak, and on and on and on. So to say that he's been in action is an understatement, because he's been in different theaters of active medicine. And I was really curious beforehand in talking with him about whether emergency medicine is the same in all places. And as you can imagine, it's not. But today he's going to tell us about something that doesn't have borders, and that's the COVID pandemic, which is everywhere, and a phenomenon that's been observed as the medical profession has gotten more knowledgeable about this promiscuous virus and what the extent of its clinical profile is and what organ systems it can affect. And the title of his talk will be "Long Haulers Are Redefining How We Think About COVID-19. So let's virtually applaud and welcome Dr. Craig Spencer.
Thanks for having me. I appreciate the introduction. A couple of those things I'd forgotten about, so thanks for bringing them back up. I'm just going to share my screen right now, and hopefully you should be able to see that. Let me know. Are you able to see what's up there now?
Yes. Yeah, we are.
Great. So thanks for having me. I really appreciate it. It's always wonderful to come and speak with my own community. I know so many of you and have met many of you in the nearly decade I've been at Columbia. I'm sure that everyone is sick of talking about COVID-19. I'm going to talk about COVID-19, but from a different perspective. And this, I think, is something that you're going to be hearing a lot more about in the coming months. And that is COVID long haulers. And I'm going to talk a little bit about why I think it's important, in addition to the fact that I see these patients nearly every day in the emergency department. But also, I'm a long hauler in a sense myself, and I think it's really important that both patient-led research as well as kind of advocacy for this growing body of people who got sick with what for many is an innocuous disease, but for many ends up actually being kind of a long-term disability. And I think there's going to be really a lot of work that we'll have to do in the coming years to better understand this. So thanks for everyone's patience as I get set up, and there's likely going to be some ambulances outside the window, but I think we're going to make it through. And if at any point you have questions, please feel free to put them in the chat, and I'll leave some time for questions at the end. Yeah, Craig,
those aren't ambulances; those are sound effects that we
all got used to.
Make it more realistic.
Yeah. Well, I just put my kid back in daycare a few days ago. Otherwise, my 2-year-old would be running up on me, which is pretty normal as well. But we'll have to virtually work that in. No, but thanks. I'm excited to be here and to chat with you. I'm really happy to answer any questions. because I think this is something that we haven't heard a lot about yet. So when I'm talking about our COVID long haulers, I'm just going to give a little bit of background on what that means and how we define that. And I'll look at some kind of previous viral illnesses and outbreaks to give us some type of precedent for what we should be expecting with people who've had and survived COVID. We'll talk a bit about my personal experience, and I want to do just a little bit of rundown with the existing science that we have to date. Much like for acute COVID, kind of long-term or chronic COVID, there's a lot more we don't know than we do know, but there is some emerging evidence that this is going to be a growing problem. And then I'll chat at the end about some next steps, the recognition, the resources, the rehab, and the research that needs to be done. So let me just get started here, and I'm going to chat about backgrounds and definitions. Sorry about the extremely bold color choices. I thought I'd try something new. I needed a change to 2020, so I hope I don't burn your retina. But in terms of definitions, when I say long hauler, I basically mean anyone who had COVID and is not back to normal in an expected time frame. And generally that means people that, normally within 2 to 3 weeks, the majority of people should be back to feeling more or less like themselves. Long haulers are people that are not feeling back to their baseline at around 2 to 3 weeks. Long COVID is kind of synonymous with long haulers. Long COVID is kind of loosely defined as people who are not back to baseline at around 1 month. And then chronic COVID is people who are continuing to have lingering symptoms from an acute infection at around 8 to 12 weeks, kind of post-illness onset. None of these are consensus definitions. These are just ones that are being kind of used in the emerging literature to talk about these kind of different subsets of people who had COVID and continue to have symptoms after. I want to chat a little bit about the precedent from SARS and MERS, so that people have an idea of why it's not all that surprising that a lot of people who had COVID are continuing to have problems after their initial infection. If you remember the SARS outbreak from the early 2000s, there was also a MERS outbreak, primarily in the Middle East. Both of these are also coronaviruses, so in the exact same family as SARS-CoV-2. This is SARS-CoV-1 here. And I just have a couple studies showing some follow-up at different intervals in Hong Kong for patients who had SARS-CoV-1 or SARS original. And what we saw in both these studies that I'm going to show you, as well as a few dozen more, it was quite clear that a subset of the population who had SARS, who survived SARS, ended up having long-term issues. So this study here in Hong Kong looked at 3, 6, 12, 18, and 24-month intervals for people who were a median age of 44. And what they found was that a big chunk of people had significant impairment of exercise capacity. 10 to 18% had symptoms related to PTSD, anxiety, and depression. And almost a third of healthcare workers who were hit primarily during this outbreak were unable to return to work up to 2 years after their illness onset because they were continuing to have issues. This is another study, basically around half of people had impairment in lung function tests that had gradually improved but were still abnormal. They quote, their exercise capacity and health status were remarkably lower than that of the general population. So it's not super surprising based on other coronaviruses that people don't just always get the virus, get the disease, and get better within the span of 1 to 2 weeks, although the overwhelming majority of people do. This is true also for other viral illnesses, which I'm sure a lot of you are aware of. We know measles is crazy in that not only is it super infectious, it has one of the highest R-naughts of any pathogen. Its ability to infect people hours after an infected person has left the room. It's the scariest in a sense in terms of its transmissibility. What we've learned a lot in the past few years is it can actually just wipe the immune system clean for the 1, 2, 3 years after an infection. And so in addition to causing a lot of other potential neurologic complaints, it can have long-term immunological issues. Many of you have probably heard about post-polio syndrome, which is onset of symptoms sometimes decades, 10, 20, 30 years after an acute infection with polio, because the virus lays dormant and can be reactivated by a bunch of different illnesses or a bunch of different reasons and create acute symptoms decades after surviving an acute infection. There's been a bunch of other studies on things like Epstein-Barr virus, Ross River virus, Coxiella, many other viruses have been proven to have these post-viral sequelae. And the reason I share all this is just to set up that, we've been so focused on this dichotomy of who lives and who dies with COVID. If you go in the New York Times or COVID tracking, the only thing that we see are the number of cases and the number of deaths. But lost in that dichotomy is the fact that there are potentially hundreds of thousands of people already who've survived, who've had COVID, but who are continuing to have some type of symptoms. And I think there's precedent for understanding why that's the case. And we probably should have been kind of more in tune and aware that we were going to have a big body of people with longer term sequelae. This is really just to show the precedent. I'm going to share a bit of my personal experience. In 2014, I was working in Guinea in West Africa during the West Africa Ebola outbreak. I was there with Doctors Without Borders. I was working in Gekudu, which was the epicenter of the outbreak, at a time when, you may remember, beds were filling up, hospitals were full, a lot of places were turning people away. It was really that kind of that big August, September, October increase in the number of cases across West Africa. And I was providing clinical care inside of an Ebola treatment center at that time. It was, as you can imagine, a horrible and daunting experience to see people die every single day. And in the process of taking care of patients, at some point I was infected myself. I didn't show symptoms until I was back in New York City. I was lucky enough to be treated at Bellevue Hospital, where I had more providers on call for me than existed in really most of the treatment centers, all the treatment centers that I worked in West Africa. And I was lucky enough to survive a disease that kills 50 to 80% of people. After my survival, for many months, I was alive, but not well. I had myalgias, I had arthralgias, I had skin things. I'd lost 25 pounds. I had a lot of kind of ongoing, concerning and really debilitating symptoms. But I was also really lucky in that I was in my early 30s. I had no other medical history. And so physically, I actually responded pretty well over the about 6 to 9 months. Most of my physical symptoms went away, and I was able to run the New York City Marathon on the 1-year anniversary of the day my fever broke, when I was being treated for Ebola. So physically, I was lucky in that I bounced back to normal, but mentally and really neurologically, that's not the case. For many years after, and even up until today, I still have chronic alterations in my ability to concentrate, in my ability to create new memories, or even just to bring up old information that I think was kind of at one point burned into my brain. And I'll share at the end an opinion piece I just wrote this past weekend in the Washington Post, but the way I described it was, it almost feels like a razor blade had indiscriminately been torn across parts of my brain, severing old memories, and kind of left glue in the tracks to make it really difficult to create new ones. If someone knew me in 2013 and then again in 2015, they wouldn't know the difference, but it's something that I am very infrequently aware of, but really haven't thought much about, quite frankly, up until now that I hear very similar complaints from a lot of people who survived COVID. So that's just a little bit of my personal experience, in addition to kind of setting the precedent, just giving a personal story behind it. And it's been interesting because now I've talked to a lot of people who are 5-6 months out from COVID, including people I work with in our emergency department who were lucky enough to survive, but who still kind of sheepishly will tell me about their ongoing illness and their ongoing dyspnea and fatigue and myalgias. And I guess I share it in a sense because I want to kind of destigmatize a lot of the illness, especially an illness that, for many are being told it's just the flu. If you're not better in a few weeks, it's something wrong with you, as opposed to something that's actually wrong. COVID and Ebola certainly are not the exact same thing by any means, but just showing, like we did with SARS and MERS and Coxiella and EBV, we know that all viral infections, regardless of their lethality, can have these longer term complications. This is just a trial that was done in Liberia, looking at some of the long-term complications from Ebola in the Ebola survivors there, the PREVAIL trial that was just published last year. And it showed basically the same thing that I mentioned in experience, and a lot of people with COVID are talking about as well: headache, myalgias, memory loss, and arthralgias. All right, so I'm going to talk briefly about what we know about COVID-19, both the acute and then really the longer term complications we've been hearing about. All of you, I'm sure, have heard that this is a respiratory virus that is really protean in its ability to infect nearly every organ system. We've seen it in the brain, we've seen it in the heart, we've seen it in the lungs, we've seen it on the skin, we've seen it in the liver, we've seen it in the kidneys. It's amazing that, for something that infects the respiratory tract, it can dramatically impact nearly every organ system in the body. So I'm not going to talk too much about that. I think that most of us have heard or are aware or have seen a lot of these manifestations. What I want to talk about is really the lingering impact and some of the patient-led research, as well as some of the, I guess, testimonials that we've been hearing, and then switch over to the research side. This was a really great op-ed that was written in July by a guy named David Latt, who was sick with COVID, was on a ventilator for I think a week, and ultimately survived, and wrote this piece, and basically saying recovering from a severe case of COVID is not like switching a light on or off. It's more like a dimmer switch where the light gets brighter, then darker, then brighter again. And basically what he advocates for is not asking people, have they recovered, but asking, at what point in their recovery or how are they recovering, making it from a passive to more of an active, because a lot of people aren't willing or aren't comfortable kind of sharing their experience in the fact that they're continuing to have ongoing issues. I mentioned that a lot of what we know to date has been patient-led. There's a couple different groups, long COVID, survivor core, body politic. These were all groups that were either, built up out of individual experiences that were meant to share collectively, or there were groups that were set up for other reasons that kind of reformatted and repurposed to bring a community of support to a lot of COVID long haulers, people that had been infected and continuing to have symptoms. Body Politic is the main one. They're based in Brooklyn. They've now put out 2 separate surveys of hundreds and hundreds of patients, outlining a lot of the symptomatology, testing, demographic characteristics, a lot of what we know or knew really early on about COVID long haulers came from this community of patient-led research, which is quite amazing. Just give a general background into what we do know, some of the basic research. This just came out actually yesterday, based on research that was done at the University of Indiana. And this basically just shows the dozens and dozens of reported symptoms. And obviously the bigger the bubble, the more likely the symptoms were to have been reported. Very similar to what I showed even in that Prevail trial, right? The fatigue, muscle aches, body aches, headache. We have things like difficulty concentrating, difficulty breathing, joint pain. So we have this really huge variety of symptoms that people are complaining about weeks and months after an initial onset of COVID. This was a piece that was put out by CDC, really the first time that they recognized long haul COVID as a thing. This was the end of July. And the summary was that 35% of people, and this is non-hospitalized patients, 35% of people who had COVID were not back to their baseline within 2 to 3 weeks. And that was true even for 20% of 18 to 34-year-olds. So it wasn't just your older patient with comorbidities. This was also true across all age groups, that there was a big chunk of people who were not back to feeling normal within the span of a few weeks after an illness. For comparison, around 90% of people who have influenza are back to baseline within 2 weeks. This is, substantially different. This was another study amongst hospitalized patients that came out in July, looking at some of the sicker patients who were treated in Italy during their big COVID outbreak there. This was all hospitalized. The mean age was 56. This was a mean of 60 days out. And when they spoke to people, only 13% were symptom-free. 55%, so more than half, had 3 or more symptoms. Fatigue, dyspnea, joint pain, chest pain were common, and nearly half had a worsened quality of life as measured by a quality of life validated score. So very clear that there were long-term lingering impacts in this population as well. So this is, this is, a non-hospitalized, this is a hospitalized. There's a bunch of other research that kind of shows the same stuff. somewhere between 5, 10, 20, 30% of people that continue to have longer term symptoms after. For those that were sicker and were hospitalized, it may even be a bit higher. The one thing that maybe you've been hearing about if you follow cardiac manifestations, if anyone follows baseball, there was one of the pitchers for the Boston Red Sox that basically that called off his season because he was diagnosed with post-COVID myocarditis. This has been a concern in Big Ten and in college sports, which have seen a lot of infections in players and have kind of wrestled with whether or not they're going to continue to play because a lot of players were diagnosed with myocarditis. We didn't know what the long-term impact was going to be. Just want to give a little bit of background into this. I don't want to go too hard into details. I just want to let you know that there's research that's going on. There's a lot more that's going to need to be done. This is one of the first articles in May outlining using MRI the cardiac impact of COVID. It's from Wuhan. They looked at 26 patients, 4 of them with severe COVID, 22 had moderate COVID. It was about 47 days after their initial illness, and over half had an abnormal MRI with myocardial edema, fibrosis, and some impaired RV function. Their statement was the presence of myocardial tissue abnormalities in otherwise healthy subjects suggests cardiac involvement as a lasting consequence of SARS-CoV-2 infection. Similar for this, that was put out in July, later in July, from Frankfurt, Germany, looking at people who had a range of presentations, asymptomatic, mild, moderate, and severe, around 2 months post-onset, and they found cardiac involvement in 78% and 60% with myocarditis. These findings were independent of pre-existing conditions, severity, and overall course of the acute illness. The one thing I will point out here that there recently was a correction because there were some statistical abnormalities in terms of the chart that was put up and the numbers that were in the body. The end result was that they made a statement, and JAMA made a statement that it didn't impact the ultimate findings of the study. One thing that did change is that some of the initial data had suggested a change in LV function. That was taken out of the correction, but everything else stands. The point being that we know there are people who get COVID who have cardiac involvement, both acutely, but it sounds like also in the longer term. There's been some work showing that COVID can directly infect the myocytes of the heart. We don't know what this means. We know that influenza and many other viral illnesses can cause myocarditis. Myocarditis in younger people is primarily viral from things like Coxsackie-B. Do we know what the long-term implication of this is going to be? No. Is it possible that we will have a subset of patients who survive that have myocarditis that end up having a cardiomyopathy? Probably. The question is it going to be 0.1 or 1 or 10% of all the people that have some type of myocardial involvement? We just don't know. And the long-term respiratory symptoms, it should be unsurprising that there are so many, because this is primarily a respiratory virus that causes a lot of respiratory issues. But just like with SARS, where we saw longer-term pulmonary function issues, bronchiectasis in SARS survivors, we're seeing that there's going to be longer-term respiratory sequelae in some people who have had COVID-19, secondary to abnormal lung function, like we saw in SARS, fibrosis. And what the early data was showing that, if you had underlying pulmonary disease and if you had a more severe infection, you were much more likely to have a prolonged post-COVID or kind of post-recovery course, which again is very similar to other viral infections. This is another piece that was put out just last month, again quoting that 30% of MERS and SARS survivors had persistent lung abnormalities, and suggesting that substantial population from COVID morbidity is going to be likely from a respiratory perspective. I threw in renal. There's a couple studies that are out there, but I just want to point out that what we saw was amongst hospitalized patients, over 40% of people had an acute kidney injury, and 17% ended up getting some renal dialysis. It's unknown. There's some studies that are going on right now about what percentage of those patients are going to continue to need renal dialysis in the long term. But the likelihood is that there's going to be a subset of patients that will continue to need chronic hemodialysis well after the pandemic is over. Neurologic, this is, I think, quite interesting because we've seen so many studies. A lot of them have been more broad, like this, the ALBA COVID registry in Spain, pointing out how nearly more than half of people presenting with COVID acutely, and this is again an acute presentation, has some neurologic symptom, myalgia, headaches, dizziness, anosmia. Anosmia is huge, anosmia nausea, so the loss of taste and the loss of smell. We ended up seeing that in a lot of patients quite early on. It was very specific for COVID itself, and in the majority of people it resolved, but there's still a lot of people that continue to have symptoms. But I think more concerning are things like, dysautonomia, myopathy, strokes, seizures, encephalitis. And what they found in this study was that neurological complications were the main cause of death in 4% of coronavirus victims. This is more in the acute, but what we've seen in more of the follow-up, 1.4% in this study also had stroke. We saw thrombotic microangiopathy, and they said this is a respiratory virus that's neurotoxic. We've seen it in the emergency department even now, with people continuing to have a lot of what is described as brain fog, difficulty concentrating, headaches, dizziness, long-term symptoms that either were captured in here, or more severe symptoms. And there's been quite a few case reports. We don't know exactly how prevalent this is, but there's been quite a few case reports linking COVID-19, I guess COVID-19 infection there, just because it's from Spain. I don't think it means it has to be COVID, but showing a bunch of cases that fit the diagnostic criteria for Guillain-Barré. And there's one here, this is again not surprising, right? We saw this with Zika from 2016. And this was another report that came out in September, just a couple of weeks ago, suggesting that any patient presenting with an acute paralytic disease like GBS, encephalomyelitis, or myositis, even without systemic symptoms, may represent the first manifestation of COVID-19. So we know that there can be these protein manifestations. Clearly, if people are getting issues like Guillain-Barré or myasthenia gravis associated with a COVID infection, there's likely going to be some long-term neurological implications for many of these patients. I think the mental health is obviously the most pertinent to this group, but also one of the areas that has been least studied and we don't know a lot about. I'm sure many of you probably have seen a lot of COVID patients, a lot of patients who either had underlying mental health issues and had COVID and it's exacerbated that, or maybe didn't have any before and post-COVID have, in addition to I think the mental health needs of everyone in 2020 have really been kind of amplified or exacerbated. There was a study, I think I point out here, that looking at SARS survivors from the early 2000s, an increase in psychiatric symptoms, including PTSD, depression, panic disorder, and OCD at 1 to 50 months follow-up. And this is from initial SARS original. This paper from July posited a role of inflammatory and clinical predictors in people that have had COVID-19. This is 1 month post-hospitalization with a mean age of 58. And those are some of the stats there in terms of what they found. Their hypothesis was that COVID-19 survivors will show a high prevalence of emergent psychiatric conditions, including mood disorders, anxiety disorders, PTSD, and insomnia. I think that there are probably some questions around methodology, and I'm sure you will all be able to better assess this paper than I would from your perspective. But I do think that it's not super surprising, nor should it be all that shocking, that in addition to the kind of the anxiety and the mental health malaise that so many have had, COVID-19, an infection with COVID-19 is going to exacerbate much of that. I saw a patient last weekend who didn't have any psychiatric history, and since COVID, once she was in her apartment for quite some time, started having what she reported as anxiety and depression, ended up getting COVID herself, got sick, and she says since then she just hasn't been the same, has been profoundly depressed. It's impacted her family. Again, I'm sure you've all heard these cases way more than I have, so can comment on this, but I'm happy to chat about kind of the other presentations. This again is in addition to a lot of the issues that we've been hearing from COVID long haulers, that when they go to the emergency room or when they go into their primary care doctors, they're told basically, this is all in your head. And it may be that there is a higher prevalence of anxiety in the people who have long haul COVID symptoms. It may be that having long-term symptoms creates underlying mental health challenges that are amplified by their ongoing struggles. I think that work is still being done. We don't know, but there will undoubtedly be a longer term impact for those that have survived. So I'm going to wrap up just in terms of the next steps and then take some questions around what we may or may not know. The first one I think is recognition, and this is kind of what I'm doing here, and I know a lot of other people are trying to do, recognizing that COVID isn't just an acute respiratory illness, that many people who get it ultimately don't get better. The way that I've been trying to describe it, and the metaphor I've been using, is like getting into a car. When you get into a car, you feel reasonably certain that you're going to get to the other side of your journey well and in one piece. And that's true, and I think that's true for the majority of people who get COVID. Over 99% of people survive, but just like getting in a car, every once in a while you might get into a small fender bender and you might feel unwell for a couple of days, or you might get into a severe accident, or there's a much smaller but still possible risk that you will get in and have a fatal accident and die. And I think that this is true kind of on a population level. We're seeing these post-viral illness, we're seeing COVID long haulers describing symptoms that even if they're only prevalent in 0.001% of all people that have the disease, once you magnify that by 7 million confirmed cases, likely somewhere around 30 to 50 million actual cases in this country, and many million cases all over the world, that very small prevalence is going to add up to a really, really big toll. So I think the first step is actually just recognizing that this exists, having patients kind of be believed and giving them the space to let them convince you that this is not just all in their head, but that there are actually other sequelae, maybe in addition to or separate from some of the neuropsychiatric complaints that we often hear. Rehab is huge. There's been a couple studies showing that the earlier rehabilitation is started, especially pulmonary rehabilitation, the less likely people are to have longer term sequelae. But even just the resources, understanding who are the providers that have seen COVID long haul patients, people that understand that this can't just be a siloed approach, it needs to be a whole patient approach to care. There's a few clinics, one at Mount Sinai, and a couple others that are starting up, to basically quarterback care for many of these patients, many who symptoms and presentations overlap with things like dysautonomia and other poorly defined illnesses that people have been talking about for quite some time. This is something that was put out in the BMJ in August by providers out in London, in the UK, basically showing the approach to the primary care workup for long COVID patients. In addition to the medical, it's the social, financial, and cultural support, the mental health support, safety netting, and referral. So it's more than just making sure people with chest pain or dyspnea get an echo, or making sure people have a mental health evaluation. It's all these other things that are happening kind of independently, but also overlapping. And I think the last thing is research. There needs to be a lot more research into what is, on a daily basis, really a growing body of people who will get this virus. And even if they don't have a severe infection, may continue to have longer term symptoms. As I pointed out, a lot of this research has already been kind of done by patient groups themselves, which is quite impressive. They've done a great job organizing and advocating. There needs to be more formal research into what the long-term sequelae are for each one of these symptoms, and then I think more generally in terms of how we manage this. So I just want to share a couple of things that I've done recently chatting about this. I wrote a piece in the Washington Post this past weekend outlining basically a lot of what I talked about here. If you're interested in podcasts, I did a podcast with Andy Slevin on In the Bubble a couple of weeks ago, looking at COVID long haulers, and I was joined by Angie Rasmussen, who's a virologist at Columbia, who talked about kind of the more cellular or more micro level, what's actually happening inside the body with many patients. And then just before this, I did an NPR show on 1A that should come out later today with some of the COVID long haulers talking about their symptoms and what needs to happen next. So with that, I will say thank you so much. I'm happy to take any questions, and thanks for tuning in.
Great, thank you so much, Craig. That was a really illuminating, worrisome, but illuminating talk. And particularly really appreciate how you approach the issue of stigma with a lot of care, and that's something that in psychiatry we deal with quite a bit, and I appreciate hearing that resonate with in your discussion.
Yeah.
So I guess I'll start with the first question. One of the things that's a real challenge in medicine is communicating risk, and it's particularly challenging when there's such a divergence between the population level risk, which in this case is really substantial, versus the individual risk, which is real but quite low. And I guess I'd love to get your thoughts on how we can do a better job communicating to the public and to our individual patients.
That's a good question. I think back of when I was in Brussels training to treat Ebola patients, and that was in early September. And at that point, the outbreak had already been going on for quite some time. There had been a lot of infections in the community, but never had a healthcare worker for the organization I was working with ever been infected. And so we all felt pretty good. The protocols were really good. We knew that the individual level risk was near zero. And about an hour before I got on the plane, we heard the first reports that one of the nurses working with our organization had gotten sick and contracted Ebola. And so almost immediately that risk level changed. It went from 0 to near 0, and that small change had a huge implication, I think, for everyone's level of unease, to the point that many people at that actually just called off their deployment on their way to the airport. I think there was a handful of people. I ended up going thinking, the risk is still so small. And I think that there is an individual level of risk that people are, kind of willing to take. I certainly was. In the end, I kind of rolled the dice and threw snake eyes. But the majority of people were okay with it. In terms of how we communicate that risk, it's hard because what we've seen over the past 6-7 months is you've had these kind of divergent communications around the risk and around the impact of this virus. As a public health professional, I'm often accused of being political when I'm trying to point out how I think the US has really failed in its response to responding well. And I try to point out also that I'm not being political, I'm being a public health expert. That's what my job is. I've warned about our ability to respond to a pandemic for many years. I saw what happened after our response in West Africa, which was not great by any means, either internationally or even within the US, and was really worried that something like this would happen. And we haven't met the bar. The reason I say that is because we've had an undermining of public health messaging since really early on. It's made it very difficult for people to know where to go or who to trust on very simple measures of disease control, whether people should wear masks, what should happen, when should people be going to the hospital. It's been really difficult to drive that narrative and have that conversation. And so I think what I and what other public health professionals have tried to do is trying to be real and honest about what the risk is, not either oversell it or undersell it. I think when we talk about things like long haul COVID, there is the potential for scaring the bejesus out of everyone that, even if you get a virus that most likely you won't have long-term complications from, there's still a bunch of people like 20-year-olds that I know that were perfectly fine before that are now on, chronic oxygen. That's certainly possible. I think it's important to relay that risk, but it's also important to put it in context and say the likelihood is extremely low. I don't know. I don't know how we successfully communicate this because we're fighting a lot of misinformation and disinformation that's targeted towards making the pandemic sound less worse than it is for other political and economic reasons. And trying to focus just on the public health is tough because it's a lot easier for a video about, kind of the fabricated origins of this outbreak or the fact that it's all a hoax to go viral on Facebook than it is for me or anyone else to get up and try to convince people of the severity of this. It's been a challenge.
So, Jonathan, I'll ask a question while you're fielding the other ones. Actually, two questions. Greg, so in terms of the sequelae that you described, is the pathophysiology been able to be parsed in terms of what is the effect of the virus and what's the inflammatory response? And then the second one is, what about pregnancy?
Mm-hmm. So that's a good question. Angie Rasmussen talked about that a bit in that podcast I pointed out. We don't know. We do know that COVID, the coronavirus, SARS-CoV-2, has been shown to infect myocardial cells. There has been some evidence that it's impacted or infected directly the olfactory bulb in parts of brain tissue, but we don't know whether it's actually that direct infection by the virus or it's longer term chronic inflammation that is kind of induced by that infection. We just don't know. It may be that there's a crossover or kind of an overlap of many of them, but at this point, it's just not clear which one of those it is.
Should treatment be dually targeted?
I don't know. Actually, I don't know enough to say. I think it's going to be different for different presentations and different tissues. It may be that in some organ systems, it's an ongoing infection with the virus itself, and others it may be kind of the longer term inflammatory. We don't know. I mean, it could be similar to things like shingles or polio where the virus lays dormant. We saw this in Ebola as well, someone who survived an initial illness and then I think 3 to 5 months later had reactivation and had an Ebola virus cultured from her CSF. It's hard to say. We don't know if it's in immunologically protected sites. We just don't know. I want to point out, I see there was a question, I think, from Elizabeth about marginalizing this into the bucket of illnesses such as chronic Lyme, ME/CFS, dysautonomia, mast cell activation syndrome, like all of these things. I feel the exact same. The question is like, I think many of whom have experienced gender dismissal of their health issues. I'm concerned about how the politics will impact. This has been the biggest issue because a lot of the patient-led research has been done primarily by middle-class white women. And that has resulted in kind of a almost sweeping dismissal by many people of kind of long COVID as a concern. Many are saying that it's directly related to anxiety, or it's like gluten insensitivity, or fibromyalgia, or all these other things that have been, I think, stigmatized or kind of marginalized and demedicalized. When I've spoken to people who are well experienced in treating things like dysautonomia, for example, they see a lot of overlap with some COVID patients they see. There is certainly a push within the ME/CFS, the myalgic encephalomyelitis, chronic fatigue syndrome group, to kind of tie a lot of what we're seeing with COVID to what is happening there for research and for more recognition. I don't directly talk about it all that often because I just don't know. It's likely that there's going to be overlap with many of these other illnesses, many of these other presentations, but I also am concerned that just because middle-class white women are more likely to come forward and have the means and resources to be able to kind of build up a group and have a support and have their voices actually heard. I don't think that necessarily represents the true burden of people who are actually impacted by this. One of my really good friends is the same age as me. He will describe himself as a stereotypical kind of macho Dominican guy. He was really sick in March and was really, really sick with COVID, and now is unable to kind of walk up a hill that he was running up and down, for an hour and a half. He can't even walk up it once 6 months out. So it's not just an illness that is confined to maybe the more vocal people in these advocacy or research groups. It's many, many other people, but you're right. It's a question of how that gets messaged and how it gets perceived. And I think a lot of that has resulted in kind of just this widespread dismissal of many of these patients as being just, having underlying anxiety or having other psychiatric complaints, and that they're somaticizing these complaints to have some relation to COVID.
So another question that was brought up by Chia Sissoko is, as a public health expert, do you engage in debates against individuals that seem to be spreading disinformation? Do you recommend actively involving yourself in such discourse?
Yeah, it's hard. It's really hard. Yeah, it's hard to just kind of stand by and see disinformation and misinformation just go unimpeded. Sometimes, unfortunately, engaging, especially people who may have a small platform but a big voice, engaging them gives them that ability to kind of spread more widely the mistruths. There is a whole disinformation science in terms of how you combat medical disinformation. That's certainly not my background. I wrote an opinion piece a few weeks ago in the New York Times with Seema Yasmin, who is an expert in medical misinformation at Stanford. And we pointed out that the biggest medical misinformation websites or groups on Facebook are clicked more than 10 times than the WHO, the CDC, or other trusted public health authorities websites. So a lot of it, I think, is the power of social media, and a time when people have a lot of questions, it's quite easy to share something that is either fantastic in one sense, or surprising, or more exciting, and that makes it go viral, and people will see that more, and that will drive discussions around the origin of the virus, or whether or not we should be wearing masks, many of these other things. It's hard to know exactly when to engage. Sometimes I do, sometimes I don't, because engaging may just give a bigger platform, but sometimes it's hard not to engage, especially when it's coming from what should be really publicly trusted authorities. That's been the bigger issue.
The next question is similar to what Jeff had asked, but is any research that you're aware of being done to look into whether corticosteroids can protect against the long-term sequelae?
I don't know of any. I'm sure that there's some being done. From those SARS original studies that I point out, there were actually a lot of long-term sequelae from the use of steroids. So steroid-induced bone issues, osteoporosis. They thought that some of the longer-term sequelae may have actually been from steroid use itself. I've seen that in a couple of studies, but I'm not sure with what's happening right now whether that research is being done. I do know, obviously, that we're using steroids primarily in patients that need supplemental oxygen, so moderate to severe. You could imagine setting up some type of survey or research looking at kind of those that get steroids and those that don't in terms of their longer term applications, but I'm not sure whether that's happening. I hope that's the case, but I'm not sure.
The steroids are being used for acute respiratory distress syndrome in that case?
They are, yeah. So actually, steroids have been surprisingly and thankfully shown to be the most effective treatment in terms of reducing mortality from moderate to severe COVID. And it's great because it's not thousands of dollars like remdesivir. It's $6 for a 1 week treatment of corticosteroids, and there's been up to there's been basically the NNT, the number needed to treat, is 8 to save one life, which is pretty impressive.
The next question is from Sally Satel, and it is it's a tough question. Can you envision the CDC recovering from its numerous missteps? Its credibility would seem to be damaged for the foreseeable future.
Yeah, this is like the thing that literally keeps me up at night. I think I said I did a show a couple of days ago and said that in some ways we're worse off in September than we were in April, because at no point in April did anyone have to question the guidance that was coming out from the CDC or the FDA. It's very clearly, and this is a public health statement, not a political statement, there has been political influence at both of those agencies. It's been well documented. It's not surprising. It is surprising. It's just saddening. It makes it really hard because now we've seen the CDC backtrack on 3 different issues. The first being outlines or guidelines that were put out for school months ago that were ultimately watered down. And basically the CDC's webpage said, send your kids back to school. We saw within the past few weeks guidance that said, you do not necessarily need to get tested if you were in contact with someone who tested positive for COVID. So for asymptomatic contacts, which is just pure craziness from a public health perspective. Like the goal is to test as many people as possible to let them know if they should isolate or if they need to quarantine. And that was reversed just a few days ago, early last week. And it was made clear through a lot of investigative reporting that this was the political thumb had been placed on the agency to make this change to public health guidance that made no sense. And then last Friday afternoon or Friday morning, new guidance was put up on the CDC's webpage talking about the potential role of aerosols in transmission of SARS-CoV-2. It quietly went up and then it was quietly removed on Monday morning. There has been reporting saying that that was not at all politically influenced. CDC officials themselves saying that they made their own mistake. It was an internal process area. They shot themselves in their foot. But immediately everyone's concern was that there had been some political involvement because there had been the 2 times before that. So that's from the CDC. With the FDA, the debacle around the announcement of convalescent plasma as giving it an emergency use authorization a few weeks ago was a mess. Statistics were misrepresented and misused. It was more political theater than it was for public health. And it's a shame because plasma may, in fact, have a really great role. We just don't know when decisions like this actually make it harder for us to have that science. And then, of course, there's this big concern about what's going to happen should we have a vaccine candidate that gets far enough into phase 3 trials in the next month or two that it could potentially be given an emergency use authorization either before the election or shortly around there. Yeah, so I have a lot of concern about how the really trusted public health agencies in this country have been politicized and the role of politics in making those decisions in a pandemic that have been left to public health organizations for a long time.
Yeah, the loss of faith in our public organizations is incredibly worrisome.
Yeah.
The next question is from Christina Brazing. You mentioned you recently had your child return to daycare. How do you think about risk with children and young people with regards to opening of schools and also with regards to college?
Good question. I think about it primarily as the community I'm in. So in New York City, our test positivity is less than 1% and has been for over a month, meaning that the number of swabs that go out, of those, the percentage that test positive are less than 1%. That's incredible. That just means there's not a lot of virus in our community, which isn't surprising. I don't see that many COVID patients on a weekly basis anymore, maybe one a shift. So for me, that's really the primary thing. Obviously, there are all the requirements that need to be in place in our daycare, for example, temperature taking, wearing masks. There's a very small group, it's only 4 kids. Because I'm working clinically and I'm teaching now and doing a lot of other things. My wife has a full-time job and is 6 months pregnant. And so we also needed that space to kind of do the rest of our life. And it felt like now was actually a safe time to do so. I think in terms of schools, it's a bigger question. Ventilation is huge. We're finding that, airflow and potential aerosolization of the virus can impact. We do know that kids are certainly much less likely to die from COVID. It doesn't mean that it's impossible for them to contract it or pass it along to family members. We've seen this. This is particularly true, of course, in older kids, high schoolers, and definitely in universities and college-age kids, where we've seen a good number of outbreaks on campuses all across the country. It's, of course, interesting because what do you expect a bunch of 19, 20, and 21-year-olds to do once they go away to college, even in the middle of a pandemic, even if they're going to be safe? There is that concern, or there is that feeling that this only impacts older people, that even if they get it, they're likely to be okay. Again, we know, and what I chatted about today was that that's not necessarily always true, but those are more likely going to be potential sources of spread into the surrounding community of teachers, community of people at universities or at schools, but then into the wider community and people's homes and really just into the general community around them. So I have a concern that, we're at the beginning of this. Kids are going back to school, kids are going back to college. There is going to be an uptick in infections in many of these places. We've already seen that's likely going to spread out to the wider community, as we saw in June and July, and that we could enter in, deeper into the fall with kind of more virus into our communities, and that could drastically change, even here in New York and other places that are attempting to open up, whether or not that's successful, or send kids back to school.
So I think that's it for the questions.
I got a few questions.
Yeah, go for it.
So I'm dating myself, unfortunately, but in medical school, I think the two least popular specialties that the students would want to go into were dermatology, because cosmetic, procedures hadn't come of age yet, and infectious disease, the latter being because we had vaccines, and this is the mid 70s.
Yeah.
And antibiotics, and then the HIV, the AIDS epidemic came, and then after that, we had swine flu, MERS, SARS, Ebola, Zika, and now this. And these pathogens, arose from two geographic areas predominantly, China and sub-Saharan Africa, and was a case of jumping species, new to the human species, and resulted from dietary or hygienic practices. Why wasn't this thing coming? And where was the WHO or the United Nations or any other body that could have envisioned the potential consequences?
It's a great question. There's I think that's a whole lecture into itself, but there is this Global Health Security Index basically saying that places like the US were perfectly or the most prepared to handle something like this. There are international health regulations, IHR, that were put in place after SARS, basically making it imperative on countries to announce disease outbreaks, and that was one of the issues early on with SARS, is that was covered up for some time by China, and there have been in subsequent years a push to have these international.
We just lost Craig. There he is.
Lost me? There we go.
Yeah.
The problem is that these aren't necessarily always well funded. The international health regulations require surveillance systems, for example, and those require a lot of money, and those require a lot of resources and a lot of well-trained people to do that work. That doesn't necessarily exist in a lot of places I work, Central African Republic or Democratic Republic of Congo, for example. The focus is primarily more on management of acute diseases like diarrhea and pneumonia and malaria. There are things like the Prevail. There was a big Predict through USAID, which was a multi-year, I think it was a 5-year grant to basically study and document zoonoses, these bugs that are more likely to come from animals to man. That ended at the end of 2019 and was not refunded. I think it's been announced that will start back up again, but they're just, it's a reactive nature of, a bad thing happens. We have SARS in the early 2000s. There's a bunch of money put into coronavirus research and vaccines that dies down after a few years, and then MERS hits, and that process is completed again. For a couple of years, there's a lot of money into coronavirus research, and then it all disappeared. In terms of pandemic preparedness, it would be, a small fraction of what we spent just in the United States in terms of economic stimulus to prepare the whole globe for pandemics. It would be way more cost effective, but it's going to be really hard to convince, the Congress, for example, to put up the billions and billions of dollars that will be necessary to do that over the next 5, 10, or 20 years. We also have with that the encroaching of humans into environments where we haven't necessarily been before. Climate change is putting humans and animals closer together. So the likelihood that a bug or a virus or bacteria is going to jump from an animal, from a forest, from an animal to someone living closer on the margins is only increasing. It's a lot, and it's quite easy for that virus to be from the forest to Forest Hill, Queens in the span of 24 hours, more so than it ever has been. So it's no surprise that in the past 30, 40 years, we've seen an increase in the number of kind of viral and infectious diseases that are traveling around the world. I think that's only likely going to increase. I think in some sense, COVID is, and SARS-CoV-2 is a perfect virus in how it spreads, but this is definitely not the worst case scenario. This is basically a starter pandemic. And unless we think about how we would respond to something as contagious as measles and as lethal as Ebola, as the worst case scenario, until we do that and prepare for that, we're unprepared.
Right. Well, just to take this one step further, from a policy standpoint, it's like so many things we're seeing the failures of our institutions that are supposed to be, minding the store and protecting us.
Yeah.
So these things emanate from specific geographic areas because of local practices, and in centuries past they were localized because we didn't have globalization, so they couldn't get out.
Yep.
But with AIDS, I mean, I was training during the beginning of the AIDS epidemic in the late 70s, and so there was the globalization that's taken place has produced like wake-up calls in a lot of different sectors of the economy. The internet globalization has roiled music and entertainment, finance. With the reactivity of the markets to like the subprime mortgage crisis and so forth. Defense, obviously, post World War II. There's been alignments. So there's been all these things, even if they were reactive, were put in place. But it's even though what was the woman's name? Lori something, who wrote that book?
Laura Garrett.
Yeah. I mean, even though there's been warnings and forecasts, credible ones, nothing's done, and there doesn't seem to be a convening authority to pressure to do it.
Yeah. I mean, the WHO is that convening authority. And it's funny, I wrote an op-ed in April defending the World Health Organization, which I work for Doctors Without Borders. I'm on the board of directors for Doctors Without Borders. The least likely person you'd expect to write an article, full-throatedly supporting the World Health Organization would be me. But it is really our best case and our best chance at fighting and preparing for illnesses like this. It is a heavily politicized body by virtue of its makeup, and it's not because it's politicized by China or by the United States. It's politicized by the fact that it gets all of its money from, donor countries like the US and Germany, et cetera, who drive the agenda specifically based on their amount of contributions. But we need to have a transnational authority that has teeth, that has the ability to both force implementation of international health regulations so that we can do the surveillance, that has the money and the support to be able to do that and kind of help with the logistical and operational needs necessary to do that. And to also kind of make decisions that are in the best interests of global public health, not kind of reactive decisions made locally that will ultimately have negative impacts on outbreaks and on the course of pandemics like this. And until we have that, I think we're all going to be vulnerable, right? We could try to put up a wall around the United States to keep COVID out. Once it's eradicated, which I don't think it will be. I think it will be endemic. But that's just not the way diseases work. Like, it will find a way. It'll find a way in. It will circulate. It will continue to cause a problem. And I think that's going to be true going forward. We need to work collaboratively on issues like this. Otherwise, we're all being left. We're all going to be left vulnerable and independent.
Jonathan, if I could just ask one last one. Could you, I know this is in your area, but could you just give us your views on testing?
In what sense?
Well, the CDC failed to have a test that it could, distribute, and so everybody was left to scramble and develop their own assays. And then we had the antigen, the RT-PCR, and the antibody. How do you view those as being informative at this point?
I think they all have a different and important role. The RT-PCR, I think, should be for patients that are going to be hospitalized, patients that are symptomatic and we need to do something about in terms of treatment. Antigen testing, I think, can be helpful if done well, and a lot of the newer antigen tests appear to be quite sensitive. And so they're cheap, they're fast, they're low cost options that can reliably be used, I think, for either asymptomatic people who kind of want to go about and do somewhat normal things, or go outside, or go into a restaurant, or things that we might want to do to get back to some sense of normal. They're not perfect. They often have false negatives, even the best of them, but they can be helpful as a screening tool. And it can certainly be helpful, the antigen test, as a, you may have COVID, you may be asymptomatic, but you're not likely to transmit. And so if you test positive on a PCR, you could have a cycle threshold of 37, meaning that you're COVID positive, but the likelihood that you're going to transmit the virus is extremely low. A lot of the antigen tests have a lower limit of detection, meaning that if you test negative, you could still have COVID, but you're likely not going to be transmitting the virus. And then the serologic testing, the antibody testing, certainly has a role if it's good quality testing. If we want to think about, documenting who has immunity, whether it's for, higher risk activities, there can be a role. The reliability of that testing and what we're actually going to do, we don't know what immunity even means anymore. Just because you have antibodies doesn't mean that you're necessarily protected. We've seen, I think, a dozen cases of well-documented reinfection. So we know that it's possible that even if you get infected, you can get infected again, even if the overwhelming majority of people probably don't have that experience. So I think each of these tests has a role, has a specific role that they need to be used. I think we could increase our testing, looking at some of the antigen testing and some of that more point of care testing, even if it's not as sensitive. I think we continue to use RT-PCR in the sense that we're using it. It needs to be fast. It needs to have a good, 24-hour, maybe 48-hour turnaround time. Otherwise, I think it's completely useless. And then antibody testing has a role, but I think these are all into different scenarios, and we haven't quite got them all in place yet.
Thanks.
So I think we've gone through all the questions, but I did want to just comment that there were a number of people writing into the chat function, just thanking you for such a thoughtful presentation. I really appreciate your time.
I appreciate it.
And,
yeah, absolutely. Thanks for tuning in, and I'm happy. It's easy to find my email. So if you have any questions, feel free to reach out.
Wonderful. So with that, I'll turn it back to you, Jeff, for final words.
I think you said it all, Jonathan. That was great, and we will try to kind of continue the interaction and hopefully leading to some kind of maybe collaboration on this, and also the media fronts, which we didn't get into today. Craig's also forged a path in terms of responsible medical communication, which is badly needed. So hopefully we can do something around that. But thanks, and everybody, we'll see you next week for the Mumford lecture, which Mark Olson and will be officiating at. And until then, stay well and stay safe. Thanks.
Thank you.